Hello there. This is Dr. Carling from the Carling Adrenal Center here in Tampa, Florida. I'm Dr. Carling, and thanks for joining me for this Carling Adrenal Center Q&A session. As many of you know, I've now been here in Florida for about 4.5 years. Before I was on the faculty and chief of endocrine surgery at Yale University. Had the opportunity to join the team down here at the Hospital for Endocrine Surgery, a super specialized hospital focused only on adrenal, parathyroid and thyroid surgery. And I perform by far more adrenal surgery than any surgeon in the world, performing about 500 adrenal operations every year. So we'll jump right into it. So thank you for writing in many excellent questions. So we'll just go through them one by one. And please feel free to comment in the comment section and ask additional questions. So the first question, I was just diagnosed with adrenal adenoma. Mine is 1.7 centimeters in size. Question, should I have it removed now or do I have to wait? It's causing all kinds of issues in my body. Well, so many of you that follow the Carling Adrenal Centers know that you have to answer 3 questions. Question number 1, is it cancerous or potentially cancerous? Number 2, is the tumor truly arising from the adrenal gland? And number 3, is it overproducing any of those hormones that make us sick? So when it comes to the first questions we want to try to answer is it cancerous or potentially cancerous? We go by the size, so if the tumor is greater than 4 centimeters, or what we call the imaging phenotype. How does the tumor look on an MRI or a CT scan? As many of you know, we never biopsy adrenal tumors because A, it cannot tell the difference between a cancer and a non-cancer, and if it is cancerous, we know that violating the capsule with a needle biopsy can cause recurrence. So A, I want to look at the CT scan on the MRI to be able to tell whether the tumor needs to be removed. The scan will also tell whether the tumor truly arises from the adrenal gland or adjacent to the adrenal gland. And maybe the most importantly, is the tumor overproducing any of those hormones? And that's where testing for the adrenal hormones come into play. But broadly speaking, you have tumors that overproduce aldosterone that can cause high blood pressure and low potassium and a lot of other symptoms. You have tumors that overproduce cortisol, causing subclinical or overt severe Cushing's syndrome, and pheochromocytomas. So a combination of the scan as well as the lab testing will determine whether the tumor needs to be removed or not. And of course, we factor in the symptoms of the patients as well. So I need a little bit more information to know whether a tumor needs to be removed. Just because it's 1.7 centimeters, it makes it unlikely that it's cancerous, but doesn't exclude the possibility that it's overproducing hormones. In fact, most aldosterone producing tumors are very small. They can be just 0.5 to 2 centimeters or so. Question number 2. Are there any specific symptoms or indicators that suggest an adrenal tumor might be present? Yes, there's very specific and some common symptoms. One common symptom is high blood pressure. Almost all adrenal tumors cause varying degrees of high blood pressure. So pheochromocytomas, which are adrenaline producing tumors, often cause high blood pressure, but it might be intermittent, meaning that the patient has normal blood pressure but then have these spikes in the blood pressure. Hyperaldosteronism, where you have an aldosterone producing tumor, you can also have varying degrees of high blood pressure, but those patients often respond very well to medication called spironolactone or eplerenone. Patients with Cushing's syndrome, too much cortisol, can have a lot of symptoms, everything from osteoporosis, high blood pressure, worsening diabetes, weight gain. So Some symptoms are more diffuse and some symptoms are more specific. But bottom line is, if you have symptoms that suggest overproduction of any of the adrenal hormones, you should be tested first with lab testing, and if that's suggestive of an adrenal tumor, you need a scan of your adrenal gland. Question number 3. Can you discuss the pros and cons of surgical removal versus other treatment modalities such as medication or radiation therapy? Well, what's true for all adrenal tumors is surgery is the mainstay, state-of-the-art curative surgery. It's by far the best treatment, the most cost-effective treatment, and the only curative treatment in almost all cases. That doesn't necessarily mean that other treatments are not occasionally needed, but radiation therapy, for instance, is used very rarely, but there are some specific instances. For instance, in a patient where adrenal surgery is not possible for an adrenal cancer, occasional radiation therapy can be used. Medications are often used as a bridge to get the patient to surgery. For instance, for certain patients with Cushing syndrome, they may need to be on medication that lower the cortisol to get the patient to surgery. There's medications such as Korlym and ketoconazole, other type of medications that lower the cortisol to get the patient in shape before surgery. Sometimes patients that are morbidly obese need to lose weight before surgery, and now with some of the new weight loss medications, they may need to be on several months of some of these new medications that you may know, meaning the Ozempic, Mounjaro, those kind of medications, in preparation as a bridge to get to surgery, because a lot of the adrenal tumors can cause weight gain and they may need to lose weight before surgery. We use medications in patients with pheochromocytoma sometimes to block the adrenaline release prior to surgery. Those medications are called alpha blockers, doxazosin and prazosin, to get the patient ready for surgery. But you can think of the medications as a bridge to surgery. That's true also for aldosterone-producing tumors. As I mentioned before, spironolactone and eplerenone are particularly helpful in controlling the aldosterone release in patients with Cons syndrome. So often patients need to go on that prior to surgery. But overall, medications don't remove the tumor. Medications don't fix the problem. They treat the symptoms and get the patient ready for surgery. But ultimately, the goal is to get to curative surgery. Next question. What specific tests are typically used to diagnose adrenal tumors? Well, we talked about the tests of imaging, CT scan and MRI, and that's pretty straightforward, so we don't need to go into that too much. But then the lab test, which can either be blood tests or urine tests, those are all designed to identify hormone overproduction. So let's start with aldosterone testing. So aldosterone is best tested, meaning testing for Cons syndrome, by measuring the potassium, which is usually low, the aldosterone, which is typically high, and a kidney hormone called renin. So you measure the aldosterone and the renin, and if the ratio aldosterone over renin is greater than 20, that's suggestive of too much aldosterone. That's sort of the screening test for hyperaldosteronism. Sometimes you need to make a conclusive diagnosis, and you may have to repeat those tests, and sometimes you can do a 24-hour urine-free, 24-hour aldosterone testing as well. Occasionally something called adrenal vein sampling, if you have no tumor on the CT scan, may be needed. But aldosterone is pretty straightforward. You measure the potassium, you measure the aldosterone, you measure the renin, and if the aldosterone is high, the renin is low, that's indicative of primary hyperaldosteronism. Next, we do specific tests for cortisol. There's about 10 different ways to measure cortisol, and that tells us a couple of things. If there was a easy way and only one test that was perfect to measure cortisol, there would only be one test, but there's about 10 tests. So that tells us that there's not a single test that takes the whole picture. So we sort of need to look at a holistic picture of what the HPA axis looks like, meaning the hypothalamus, pituitary, adrenal axis. So we look at the combination of pituitary labs, meaning ACTH, which is the pituitary master regulator of the adrenal gland, as well as the cortisol levels. And the best way to measure the cortisol levels are the low dose dexamethasone suppression test. The way that works is we'll give a low dose of dexamethasone at 11 p.m. in the evening, and then we measure the cortisol. Normally, in a normal individual, that should suppress the cortisol, so the cortisol the next morning should be 1.8 or below. If it's 1.8 or higher, that means that you fail to suppress, and that's an indication. That's indicative of Cushing's syndrome. We also measure the DAAES, which is a prohormone of the adrenal gland, and if that's on the low side, that's also consistent with high cortisol. Sometimes salivary cortisol is measured. We use 24-hour urine-free cortisol, meaning we collect the urine for 24 hours and measure the cortisol. I should say, and a lot of people don't know that most patients with subclinical Cushing syndrome, which is the most common cause of adrenal Cushing syndrome, most patients have normal 24-hour urine-free cortisol. So every week I hear patients that say, well, my endocrinologist told me my 24-hour urine-free cortisol is normal, so you can't have Cushing syndrome. That couldn't be further from the truth. 95% of patients with subclinical disease have a normal 24-hour urine-free cortisol. So that test is great for patients with severe Cushing's syndrome, either from an adrenal cancer or from a pituitary Cushing's disease. But for patients with subclinical disease, or what we call mild autonomous cortisol secretion, that test is not very helpful. It's only elevated in 5%. Finally, the specific test for pheochromocytomas are relatively straightforward as well. That has to do with plasma or 24-hour urine catecholamines or metanephrines. Those are adrenaline type hormones. So you measure them either in the plasma or you collect the urine for 24 hours. And those levels are usually quite conclusive. There's certainly some patients that we see that have pretty minimal amount of elevation in catecholamines and still have a pheochromocytoma. So next question, how long after an operation does the cortisol level go back to normal? That's a great question. So a lot of patients have questions about this, and I encourage every single patient that has subclinical Cushing's syndrome or think that they have it or are interested in cortisol metabolism to read the most recent blog on adrenal.com that talks about subclinical Cushing's, recovery afterwards, what's the role of partial adrenalectomy, as well as how often do patients need to go on supplementation afterwards. But bottom line is, how long after an operation does the cortisol level go back to normal? In general, it's dependent on how high the cortisol levels are going in and how long the patient have had the disease for. So the higher the cortisol levels going in for surgery and the longer the patient has had Cushing's, the longer it takes for the normal cells that's been suppressed by the high cortisol to kick in and start producing cortisol. So in many patients that have more mild disease, many patients don't even need to go on cortisol after. That's the majority of patients. We check the cortisol level the next morning, it's completely normal, they never need to go on hydrocortisone. For those patients that have more mild disease, they may be on hydrocortisone for a few weeks to a couple of months. But if you come in and have very severe Cushing's syndrome due to big tumor that's producing a boatload of cortisol and you maybe have had it for a few years, yeah, then it can take some time. It can take 6 to 12 months, sometimes even longer. So it all depends on how severe the disease is when you operate. So the more severe the disease is, the longer it takes for the cortisol levels to normalize after surgery. All right, so we just got another question in here. It says, I have one adrenal gland left. How long will it continue to do its job? Well, as long as you have one adrenal gland, it will do its job the rest of your life. So we have two adrenal glands. If it's enough to have half of one gland, so you only need half of one gland to have normal function. So if you have one normal adrenal gland and your cortisol levels are normal, meaning they're not suppressed but you have normal function, that adrenal gland is going to function the rest of your life. If, for instance, you develop a tumor on the remaining adrenal gland, and we see a lot of patients like this, we can always do partial adrenalectomy. So key is to preserve at least 30 to 50% of one normal adrenal gland, and you will have normal function the rest of your life. A lot of great questions coming in, so thank you for sending this in. Next question. This is another great question. What questions should I ask a surgeon to determine if they are qualified for this type of surgery? Great question. So number one, you want to ask specifically what operation they're going to perform is. So unfortunately, still, we're trying to get the word out there about the mini-back spironectomy, which is by far the best operation going through the flank. But still, most surgeons in the United States and in the world still do this operation through the belly. The downside with that is just to get to the adrenal, you have to do a lot of work. So instead of a 20 to 30 minute operation, it can be a 3 to 5 hour operation. And even longer than that if you throw in a robot into the mix. But what you want to ask is, how many of these operations have you done? How many do you do on a yearly basis? And how will you do the operation? If they don't know about the mini-back spironectomy, what's called the posterior retroperiscopic adrenalectomy, that's a concern. If they do fewer than 50 of these operations a year, that's a concern, meaning that means they only do one or so a week. In general, it's very rare for urologists, surgical oncologists, general surgeons, and minimally invasive surgeons to have a significant experience. The ones that tend to have the most experience are endocrine surgeons that have done formal training in endocrine surgery. But even among endocrine surgeons, there's very few that do significant numbers of these operations, and very few that do the mini-back spironectomy through the back. So those are some of the questions you wanna ask. If a surgeon becomes defensive about those kind of questions, that's always a warning sign as well. So if they, the other thing I would say is it's always helpful to talk to people within the community. There's a great community here on Facebook and social media. You can talk to friends and family members, as well as there's ways to look up the statistics from hospital as well. But key is experience, and experience with novel technologies. Okay, this is another great question. So for international patients, should we have all the tests done in our home country first? Will you do everything needed for evaluation while we are there? Yeah, that's a great question. So we do see a lot of international patients. So we see a lot of patients from Canada, Mexico, South America, Europe, Asia, patients from New Zealand, Australia, India, and so forth. And the testing, meaning the lab testing for cortisol, aldosterone, adrenaline type hormones, are available in all countries essentially. Even I spent some time in Uganda, and they can test for adrenal hormones in East Africa as well. So it's pretty much available. And most places, they may not have readily access to an MRI, but certainly a CT scan. So you can have the basic testing initially, and you will have a pretty good idea. And we can interpret, so different countries have different reference levels when it comes to lab testing, but we can translate that, and we're used to working with international patients all the time. So bottom line is you can pretty much have all the diagnostic testing at your home institution. Come here for your operation, and we'll do some testing while you're here, but you'll have a diagnosis even before you come here. So that can be taken care of at your home country. Here's a great question. So how many pheochromocytoma operations have you done in the last year? Yeah, so by far more than anybody else in the world. So on average, we do about 2 to 4 pheochromocytomas a week. So over the course of the year, I have to look back on the exact numbers, but out of those 500 operations, if I don't remember erroneously, somewhere between 15 to 16% of pheochromocytomas. So somewhere in the neighborhood, 70 to 100 pheochromocytoma operations in a year. Do you require a doctor referral? And if I travel to your center for surgery, can I guarantee you will be my surgeon? Yes. We do not require a doctor referral. Many patients find us online and sign up automatically. We ask that you provide information of your doctor if you feel so inclined, so we can get some of your medical records, and you sign a medical records release. And if you travel, can I guarantee you will be my surgeon? Yes, I'm the only surgeon that do adrenal surgery. We have 11 surgeons in our group, 6 surgeons that do parathyroid surgery, 4 surgeons, actually starting today, 5 surgeons do thyroid surgery, but I do all the adrenal surgery. So for sure, I will be your surgeon. Here's another great question. How do you determine if any part of the gland is salvageable? I have adenomas on both glands. This is a great question. So how can we know if we need to operate on both adrenal glands, and what part of the adrenal gland we should preserve? So again, get back to the principle. You have 2 adrenal glands. You need at least half of one gland to not need to take long-term steroids, meaning hydrocortisone or prednisone. So we want to be able to remove the tumor or tumors on both adrenal glands, but at the same time preserve enough normal adrenal tissue that you don't need to take hydrocortisone long term. So the way that works practically is when you come here the morning of the operation, I would usually start on the largest side first. So let's say, for instance, you have a 4 centimeter tumor on the right side and a 2.5 centimeter tumor on the left side. The morning of the first operation, which we would address the right side, I do a very specific adrenal protocol, CT scan, a protocol that we set up ourselves that gives a very detailed information where the tumor is in relationship to all the important small vessels, but also where there's a normal remnant. And based on that scan and based on that first operation, let's say I preserve 20 to 30% of the right adrenal gland and remove the tumor. We would, in most cases, want to let that remnant heal for a few weeks, usually about 6 weeks, and then we come back and remove the tumor on the other side. In that way, we found that almost no patients need to go on hydrocortisone, prednisone, even in the short term, meaning there's no period where they need to take steroids. So there's a combination of intraoperative findings, meaning what I see as I'm doing the operation, together with a very careful pre-planning CT scan. Another great question. What are the advantages of mini-back scope adrenalectomy versus robotic surgery? Yeah. So the robotic adrenalectomy is done through the abdomen, number one. So if you operate on the right adrenal gland, you have to move the right colon, the right kidney, you have to move the liver, you have to move the vena cava that brings all the blood back to your heart. So that means the going through the belly just to get to the adrenal might take 1, 2, 3 hours depending on the skill of the surgeon. Also, the robotic requires bigger incisions because the ports are bigger. So going through the abdomen with bigger ports creates more pain, more risk for hernias, a longer time to recovery, more pain medication, longer time to get back to work, get back to the gym, normal physical activities. And the operation takes 3 to 5 hours. And typically, what we found is all high volume surgeons tend to use the mini-back scope adrenalectomy and they don't use the robot. So usually using robotic surgery is associated with a less experienced surgeon. Conversely, the advantage with the mini-back scope adrenalectomy is that it's faster, it's better, less mobilization, so it's safer, and much better cosmetic outcome, less pain, faster recovery, faster back to normal activities, gym, work, and so forth. There's a whole section, both in the blog section as well as on the website adrenal.com, that spells out in detail all the advantages of the mini-back scope adrenalectomy, which is the best operation. Another great question. How often after adrenal surgery should cortisol and ACTH be measured? Surgery was 1.5 years ago and it's been tested a couple of times since, but now my endocrinologist says I don't need to test them anymore. Well, so I don't know the exact nature of what the testing shows, but if the endocrinologists don't want to test it, I assume it's because it's normal. So that means your HPA axis, meaning the hypothalamus, pituitary, adrenal axis is back to normal. Your adrenal glands are now producing the normal amount of cortisol because your ACTH and cortisol are normal. So if that's normal, it's going to stay normal. That's not going to change. You only need testing as long as you require ongoing hydrocortisone or prednisone treatment. That's really when we do the testing. Once that normalizes, and again, if you have more than half a gland and your cortisol levels and ACTH levels are back to normal, that's going to stay normal unless something very unusual would happen, such as trauma to the adrenal gland and you have a bleed into the gland or something like that. But otherwise, you should be good to go. Here is another great question. I was recently diagnosed with an adrenal tumor. However, I am pregnant. Should I have this treated now or wait until after I give birth? That's a great question. So should you have surgery for an adrenal tumor during the pregnancy or wait until after delivery of the baby? So it depends on a lot of things. So almost all patients that are pregnant and have mild cortisol overproduction or hyperaldosteronism can be safely managed during the pregnancy and have the baby delivered and then have adrenal surgery after the delivery. If there is concern about adrenal cancer or a pheochromocytoma, occasionally there is more urgency with surgery. And we certainly operate on pregnant patients. We had a patient not that long ago that we operated on here who had a pheochromocytoma. And when you operate on the adrenal gland during the pregnancy, the sort of window of opportunity, if you will, for surgery is in the second trimester. So ideally you don't want to operate in the first trimester because the baby is more vulnerable, and not in the third trimester because of the size of the uterus and the size of the baby, making it just more technically challenging, just because there's not a lot of room, to be frank. So the second trimester is the best time to operate during the pregnancy. But again, in most cases, this can be managed with medications, also with pheochromocytoma. So not all pheochromocytomas need to be operated during the pregnancy, but can be managed with alpha blockers medications until after the pregnancy has ended, and we can take care of the adrenal tumor shortly after birth of the baby. Next question is, can a patient recover completely from an adrenalectomy? Not the surgery, but the symptoms. How long does it take to recover and be back to a normal life? Yeah, this is a great question, and again, it's dependent on what type of tumor you have. So what I usually tell patients, for instance, patients with pheochromocytoma, they come in with heart palpitation, very high blood pressure, a lot of tremor, sweating, and so forth. Those patients, we essentially watch them being cured and recovered in the operating room. As soon as I remove the tumor, boom, like that, the blood pressure normalizes and they're cured. That doesn't mean, they can have a little bit of those symptoms, but they recover, normalize, recover, very, very quickly. Aldosterone producing tumors are sort of medium, meaning it usually takes several weeks for the blood pressure and the potassium to normalize. So it's more of a gradual thing. So over 1 to 2 to 3 months, you see recovery of the blood pressure. They feel better, the anxiety goes away, their insomnia gets better, the frequent urination and so forth. So a few months to 3 years. And with cortisol producing tumors, again, it's very much related to how high the cortisol is going in and how long have your patient gone for it. So again, the more severe the Cushing syndrome is, the longer it takes to recover. Some symptoms will get better faster. So a lot of the neurocognitive symptoms, meaning the mental fogginess, problem with concentration, anxiety, depressive symptoms, panic attacks, those kind of symptoms usually tend to get better a little bit quickly. But if we study this scientifically, for instance, the effect of bones. So cortisol is a very toxic hormone, it's very catabolic, including on bones. So it causes osteopenia and osteoporosis. So if we study the bone mass on patients that have been operated on for adrenal Cushing syndrome, we see improvements in bone mass 3 to 5 years after the operation, meaning some of the toxic effects of the cortisol takes quite some time to normalize. So the patients will recover. It's just a question of time and a question of what type of tumor and what kind of hormone was being overproduced. Here's a question about adrenal Cushing's. Can you test positive for Cushing's syndrome if dexamethasone suppression test comes back elevated or abnormal? Yes, so this comes back to the testing for Cushing syndrome. So the three major tests, there's some additional tests, but the three major tests are, you see an ACTH that's suppressed, you failed to suppress on a low dose dexamethasone suppression test. That means the next day after taking the pill at 11 a.m., if the next day the morning is 1.8 or higher, you fail that test. And that's indicative of Cushing's. And if you have a DHEAS that's 100 or below, that's indicative of Cushing's syndrome as well. So certainly, if you test positive for Cushing, if you fail your low dose dexamethasone suppression test. Here's a question about a patient who had gastric bypass and my gallbladder removed. So previous gastric bypass and gallbladder. I was told I have too much scar tissue for adrenal surgery. What should I do? This is a great question that brings up a very important point when it comes to mini-back spironectomy versus laparoscopic or robotic or transabdominal surgery. Meaning, the beauty of the mini-back spironectomy is we never enter into the abdominal cavity. So you have the abdominal cavity, but behind the abdominal cavity is what's called the retroperitoneum, and that's where the adrenal gland lives. So traditionally we would do this operation through the belly, and one of the problems is if the patient ever had previous abdominal surgery, like this patient. Previous abdominal surgery causes a lot of what we call adhesions. Adhesions are scar tissue, meaning if you ever had a gastric bypass or colon surgery or gallbladder surgery or any hernia surgery, any intra-abdominal surgery, going back into that field is a lot of scar tissue. And the scar tissue, more scar tissue, means the bowel is plastered to each other, much greater risk of having a bowel perforation or a significant complication. So the beauty of the mini back scopiolectomy, we don't even have to go into the abdominal cavity. We make 3 small incisions in the back, get right on top of the kidney, which is in the retroperitoneum, and the adrenal gland is sitting right there. We don't even see the bowel. There's no need to dissect out the bowel. There's no need to dissect out any of the intra-abdominal contents, because the adrenal gland is not in the belly. The adrenal glands are in the retroperitoneum. So the point is, you may have too much scar tissue to have a transabdominal operation, but since the operation should be done through the mini back scopiolectomy, it doesn't matter that you had gastric bypass, it doesn't matter that you had gallbladder surgery. The best operation is to go through the back, and you don't even have to worry about that. So you don't have too much scar tissue, you just have a surgeon who doesn't know how to do the best operation, the mini back scopiolectomy. Here's a question about primary hyperaldosteronism. I had primary hyperaldosteronism for years. I had all the symptoms, worst of all, excessively high blood pressure. My 2 questions are, why did a tumor grow on my adrenal gland and cause this condition in the first place? And 2, even though the tumor has been removed, is there a possibility that this condition has done so much damage that stroke or heart attack is still a strong possibility? Okay, this is a great question. So the first part of the question is, why do adrenal tumors develop in the first place, especially aldosterone producing tumors? So when I was at Yale, I ran a lab, and we actually published the first scientific papers on this specific topic in a landmark publication in Science in 2011. So what we did is that we sequenced the entire genome, what's called the exome, meaning the protein coding regions of these tumors, and find that what happens is, in many cases, is that you have a mutation in a gene that controls a potassium channel. And now that potassium channel is no longer specific for potassium, but you have leakage of sodium into the cell, and that leads to the cell starts growing uncontrollably, and they produce too much aldosterone. Why you develop that mutation in that potassium channel in the first place is completely random, meaning there's no environmental factors, there's nothing you could have done to prevent it, and nothing that you did to cause it, meaning smoking is not related, obesity is not related, there's no environmental factors. So you just, you were unfortunate that you developed a mutation in this particular gene, and you developed the disease. Since then, there's been about 6 other genes since we wrote that landmark paper, and some of the other genes we identified as well. But we know why people develop these tumors. We don't know why you develop a mutation in the first place. As you know, as cells divide, there's a certain amount of rare genetic alterations that happen, mutations that happen spontaneously, and most of them are not significant, but occasionally they are in this case, and why we develop, why we have this system of inborn mutations that occur, I think is a philosophical or even a theological question. So I think we have to ask our Creator to figure that out. I don't think anybody knows. But secondly, even though the tumor has been removed, is there a possibility that this condition has done so much damage that stroke or heart attack is still a strong possibility? Yeah, great question. So, aldosterone is a very toxic hormone. It particularly puts patients at risk of stroke, heart attack, kidney failure, atrial fibrillation. Those are the four big ones, and they're all very scary and obviously associated with significant morbidity and mortality. And we know that the risk of stroke, for instance, is elevated about 400 to 1,000% in patients that have high blood pressure due to Conn's syndrome compared to patients with essential hypertension. What we also know is that removing that aldosterone producing tumor markedly decreases your future risk of developing strokes, heart attacks, atrial fibrillation. But there is certainly some amount of damage that occurs, so the risk of those devastating complications of the disease does not return back to normal, meaning you're not going to be as healthy as if you have never had that aldosterone producing tumor in the first place. But what we do know that your risk dramatically decreases. So there's still a slightly increased risk of those things happening just from the fact that you had a tumor, but the sooner you get diagnosed and treated and get that toxic tumor removed, the better off you are. Here is a question about I think this is at what HUD size, so I think it's going to be Hounsfield unit size should an adrenal gland tumor nodule be removed. So just to give a little bit of background, when we talk about CT scans of the adrenal gland, and you may read your own report that talks about Hounsfield units. The short of it is HU, Hounsfield units on a tumor. So Hounsfield units is a measurement that the radiologist uses to determine the density of the adrenal gland. And the density is mainly related to how fat containing the adrenal tumor is. So simply put, the more fat containing a tumor is, the lower the Hounsfield units are, and the more likely that it's not cancerous. So the lower the Hounsfield units are, the more fat containing the tumor is, and the less likely that it's being cancerous. This is, not, black and white science. It's not a perfect science, but in general, a benign adenoma is going to have low Hounsfield units. So going by the Hounsfield units in of itself is not a determinant for surgery. You have to take the whole picture. Again, a holistic view. You have to look at symptoms. You have to look at growth rate. You have to look at what the hormone levels are. But in general, the higher the Hounsfield units are, on a non-enhanced CT scan. So this is an important point too. So when you do an adrenal protocol CT scan, first you do a phase without contrast and then with contrast. As you inject contrast, the density goes up. So you have to be cognizant to compare the Hounsfield units on a non-enhanced, meaning without contrast, and the enhanced contrast. But bottom line, the lower the Hounsfield units are, the less likely that it's cancerous. But relying on the Hounsfield units alone is not sufficient to make a decision whether you should have surgery or not. Next, we have a question about MN2A. So the question is, how many MN2A patients do you see? How common is it? So MN2A is a genetic disorder. It's an autosomal dominant disorder, meaning that if one parent has it, they have a 50% chance of passing on that gene mutation onto their offspring. And MN2A is caused by a mutation in a gene called the RET proto-oncogene. That's RET, which stands for rearranged during transformation. RET gene, and that's an oncogene. So there are a number of kindreds in the world and in America where MN2A runs in a family. And these patients are prone to develop medullary thyroid cancer, which is the most common one that occurs in almost 100% of MN2A patients, pheochromocytoma, so adrenaline producing tumors of the adrenal gland, and also parathyroid tumors. So MN2A is relatively uncommon. Carriers is somewhere between 1 in 3,000 to 1 in 30,000, but cases that are diagnosed are a lot less than that. So we see of all the pheochromocytoma patients, so I had a question about that previously, we do about 70 to 100 pheochromocytoma cases. Out of those, somewhere in the neighborhood of 10 to 15 a year are genetically linked. So approximately 20% of all pheochromocytoma has a genetic predisposition, and out of those, the majority have MN2A. So in reality, we see between 5 to 10 MN2A patients every year that have pheochromocytomas. Medullary thyroid cancer is a lot more common, so our thyroid surgeons at the Claimant Thyroid Center see more MN2A patients because pretty much 100% of MN2A patients get medullary thyroid cancer. So bottom line, we see more patients with familial pheochromocytoma and paraganglioma than anybody else in the world, and out of those, a majority have MN2A. Next question. When you have an adrenal tumor, do you remove only the tumor or the whole adrenal gland with the tumor? Yeah, great question again, and we alluded to this a little bit. So when you decide whether you should remove the entire adrenal gland or do what's called a partial or cortex sparing adrenalectomy, has to do with the size of the tumor, has to do with what the underlying pathology is. For instance, how concerned are we about cancer? Is it a pheochromocytoma, not a pheochromocytoma? And is it genetic that the patient have tumors on both sides or not? And what does the tumor look like on the scan, meaning is it there a nice rim? So of course, goal number one is always to remove the tumor completely and have what we call negative margins. But as long as we can complete goal number one, we can also look at goal number two, which is to preserve adrenal tissue. So in most cases, that's a possibility. It's almost easier to explain when partial adrenalectomy is not advantageous is if there is a significant concern about adrenocortical cancer. You never want to risk spilling cancer cells because it will grow back, or have positive margins because that's potentially fatal. For the bigger the tumor is, the less normal adrenal tissue you have to play with, so to speak. But almost all tumors that are less than 6 centimeters, there's a possibility to do a partial adrenalectomy. Of course, partial adrenalectomy is even more important if you have bilateral tumor. It's less crucial if you just have a tumor on one side and the other adrenal gland is completely normal. Next question is, what are good practices for your lifestyle while you are in the wait and see phase for a pheochromocytoma tumor? Well, so first of all, I don't know what the wait and see phase in pheochromocytoma is, meaning if you have a pheochromocytoma, you should get diagnosed and have surgery ASAP. There's no wait and see. I presume this has to do where maybe the lab testing is equivocal and you have yet to reach a diagnosis. I think often patients with pheochromocytoma can notice some precipitating factors that can cause what we call a spell or an adrenal crisis. And that can be anything from drinking tea or coffee or alcohol, or certain cheeses can cause precipitation. Sometimes even having a bowel movement when you increase the intra-abdominal pressure can cause symptoms. So as much as you can avoid some of those precipitating factors, that's good. But bottom line, if you have a pheochromocytoma, you need to be treated and have surgery. So this is our last question. This has been a lot of fun, and again, thank you so much for sending in all your great questions. This is a question when it comes to logistics when the surgery. So how soon can I fly after surgery? I will be coming from out of state. Yeah, so the majority of our patients come from out of state. So more than 50% of patients fly in for their surgery, both international patients and patients from all around the country. So in general, if you have surgery on day one, let's say for example you have surgery on Tuesday, patients would fly in, come in latest Monday, have the surgery Tuesday, stay one night in the hospital, be discharged from the hospital on Wednesday, and then travel back on Thursday. There's some rare exceptions to that rule, but bottom line, you can travel the day after you're discharged from the hospital. As you may know, we have a shuttle and hotel partners that we work with, so most people would take the shuttle over to the hotel, spend one night there, and then fly out the next day. So thank you very much. Again, thank you so much for all these questions. I'm sure we'll try to do this again, and I hope you guys have had a great Easter and have a great rest of the week. Thank you very much.